Now, the third wave is having an impact on all of us, the economy, of course, people who lose family members. The healthcare system is under enormous duress, particularly here in Gauteng, where you can't find a bed. Having recorded well over 10,000 new cases for 5 days in a row, hospitals are overburdened. On the other hand, some people are still reluctant to receive their vaccine jab. UCT Emeritus Professor Jonny joins me now to discuss various issues around the COVID vaccine, but more importantly around the Delta variant. Jonny, thank you for joining me now, Professor Myers. We want to know, this third wave driven by the Delta variant. I had a conversation last Sunday on this show with Professor Barry Shube, who chairs the Ministerial Advisory Committee on Vaccines and on COVID-19. And I specifically put to him this issue of the Delta variant at the time. So this is just Sunday, literally 6-7 days ago. This is what he said. Let's watch.
The Delta variant is, well, so far it's been fairly well contained. It's been people that have travelled into South Africa. So far it hasn't, of the isolates which have been genotyped, close on 99% have been B351, the beta variant. So far, neither the alpha variant or the Delta variant has spread extensively. This is not to say that that will always hold like this, but for whatever reason, and this we don't understand scientifically as yet, the beta variant seems to dominate in this country.
So he does say it may not always hold like this, but literally 3 days later, suddenly we were reporting on the Delta variant becoming the most dominant variant driving new infection in this country. Why is it, in your view, what do you think the reason is that the person who heads up or is the chair of the Ministerial Advisory Committee is not in the loop? Is he not getting data and information in time?
Look, I don't know. I can't really speak for him. What I think is that this information is fairly difficult to come by. I've been trying over the last couple of weeks quite strenuously to get information from my virologist friends to find out what's going on, because the Delta variant was reported here as far back as in April, and it was imported here. And I noted that Prof. Shube mentioned that it was well contained and it was just some people who'd come in from outside. But I don't think, unfortunately what's happened is that it's quite difficult to do these tests. And there was a report that actually came out yesterday which shows that the Delta variant has almost completely taken over from the beta variant. So there's no mystery about the beta variant. It's inferior evolutionarily speaking to the Delta, which has taken over, and it's for the country as a whole. It's taken over in KwaZulu-Natal almost totally, and then fairly substantially in Gauteng. And it's all in really since the middle of May or the end of May, and it's now also present in the Western Cape.
And why are these two provinces the most vulnerable, and what comes next?
It's interesting. I mean, the KwaZulu-Natal isn't very vulnerable, I don't think, because they seem to have had a very bad second wave of the pandemic. And if you look at their rates are rising the slowest out of all the 9 provinces. Gauteng was actually vulnerable because their cumulative rates, and I'm talking here about excess death rates, because that's the hardest indicator we've got, have been very low. They've been right almost at the bottom of they've been the least impacted in severity of COVID of all the provinces, and they're now being hit very hard because they haven't built up a lot of natural immunity.
So tell me what happens next. I mean, you've done an analysis of various provinces. You've just talked about why we in Gauteng are more vulnerable because we didn't face a severe second wave. What does that mean for some of the other provinces? What do they have to look forward to?
Well, this is what I think, that basically there is this differential vulnerability in the provinces, and it's there now, and it's going to be there going forward. I think that cumulative excess death rates show that the most vulnerable provinces are the Northwest, Western Cape, Gauteng, Limpopo and Mpumalanga. And the case rates in all of these have either gone up very steeply in the case of Northwest or are going up very steeply. That's still going up Northwest. The least vulnerable provinces are the Northern Cape because it went up. That was the one that's really kicked off our third wave a couple of months ago and has gone up very high, and then now it's come down. So it's sort of finishing off its third wave, but the least vulnerable ones are Eastern Cape and KZN and the Free State, all of which have had quite impactful, they've been quite severely impacted by the second wave, and in the case of the Northern Cape and the Free State, the third wave. I don't know if that makes sense.
Yeah, it does, and I'm sure that those living in those provinces are probably relieved to hear you say so and make those sorts of predictions based on what's happened with previous waves. Now, obviously, we need to accelerate the vaccine program to try and protect as many people, but when you're in the middle of this wave, it's not much use. I mean, we should still go ahead and do it, but it's not like it's going to protect you immediately. You're pretty much going to have to ride out this wave using, what we call non-medical interventions.
Well, yeah, absolutely. I think that, vaccine takes at least a month to kick in after you've had your first dose of, say, Pfizer. So I think, but nevertheless, I think we really do need to accelerate vaccination as fast as we can, because we're not only going to have a third wave at this rate, we also have to look to the future. We've got to look to a fourth wave and possibly a fifth wave. So, but in terms of, you're quite correct. I mean, it will even NPIs, non-pharmaceutical interventions, are not going to work terribly well in Gauteng, for example, at the moment, because they must be right up somewhere near the top of this very steep curve they've been climbing in terms of cases. But there are things that I think can be done. And again, I think it's quite important that these things differ by province. We always have one size fits all so far in the pandemic in South Africa, but now we've got quite a spread between the different provinces. As I said, we've looked at Northern Cape, we looked at Northwest and Free State. They've sort of had, hopefully, their third waves. We're going to get next Gauteng and the Western Cape and probably Limpopo, and the others are going to come along later. So there could be a differential type of I don't want to call it a lockdown. Let me call it non-pharmaceutical interventions. We can't afford a real strict lockdown because we're just not rich enough as a country, and it's not fair on the poor and the vulnerable who've got to go out and work and put bread on the table.
Prof, let me end with this question.
Yeah.
A lot of people in South Africa, very much in the first wave, reached out. I guess they would reach out for anything. But one of the things that trended in this country was Ivermectin, and not just here.
Yes.
And recently I've seen, surprisingly, that some very reputable universities are actually investigating it again. And I'm sure, many South Africans talk about it as an option when they can't get the vaccine. Is there any merit in that at all?
This is part of the whole pattern of things. When we're faced with something as severe as this epidemic, people grab a hold of all sorts of things. And to me, this is like one in a succession from hydroxychloroquine, colchicine, and so on and so forth. So I think that it's very simple what's going on. I think that, in fact, there's been a very, very good review of the evidence published on the National Department of Health's website, which I recommend people have a look at. It's very, very thorough review, and they have found no merit in any of the studies. The randomized controlled trials that have been run so far, they're all too small. They can't show any real effect, and there have been many flaws with these studies. So the thing is, what you've seen is that Oxford and McMaster University are going to be they're starting a big trial to get sufficient numbers to be able to do things properly, have a properly constructed trial, and then we'll know. As with the other agents that people had hopes for, once the proper trial is done, you really know. And that's what both the McMaster people are saying and the Oxford people are saying. We don't know. We have to do this trial, and then we'll know. But in the meantime, there is actually no reliable evidence to show that Ivermectin works despite people's high hopes for it.
Professor Jonny Myers, thank you so much for your time and your wisdom and advice to the people.